Hey everybody, welcome back to the Pre-Hospital Paradigm Podcast. I'm Scott Wildenheim. I got my whole crew here this time. We've been broken up in previous episodes, but we got everybody here today. Down at the end there, we've got Ray Pace, got Caleb Ferroni here to my left, and Dr. John Hill to my right. And this month has been, hopefully everybody's been able to look at the pre-recorded sessions, and it's been a capnography talk all week. So we'd really like anybody that's out there and on Facebook, YouTube. Hey, any questions? We can see those. We can see those here, and we'd love to talk through them and answer them live on air. So we are live at UH Portage Hospital in Ravenna, Ohio, and behind me there, I've got the entirety of the UH Portage evening paramedic class. So everybody say hi.
They were all forced to be
They
here.
were all forced to be here. We were hurting so badly for attendance and participants that we told them that they were going to come here. They have a whole battery of questions for us that we're going to get to here in just a little bit. But first, we got to dispense with all the housekeeping stuff. First of all of this is brought to you by AT&T FirstNet and streamed out on the FirstNet cellular network, the cellular network for EMS and first responder providers. All of that is on the backbone of Cradlepoint. They actually provide us with the hardware interface to get out into the world. So all this is being brought to you by FirstNet and Cradlepoint. So of course, thanks to both of them. If anybody's interested and not already a FirstNet subscriber, you can go on to prehospitalparadigm.com /FirstNet, and there is a special offer for you just for watching. Like we've been asking all along, if you're watching this content on YouTube, we'd love for you to hit that subscribe button. That's important to how these algorithms send stuff out in the world, and we're fighting a battle against algorithms. It's bad enough we have to take care of people, but then we also have to jank the system. All right. Likewise, these last 2 months we have been off-site. The last month we were at the fair, and this month we're here at the paramedic program. We're going to get back into our regular visits of our EMS departments and our services that are UH Med Controls. If you're interested in having us come out to your department, prehospitalparadigm.com. Click on the podcast. Down at the bottom, there's a host podcast, and we'll put you in. We're going to draw later this evening. We're going to draw whoever the next department is, and we'll be heading there next month. And also, of course, prehospitalparadigm.com, which is where all this stuff is located. That is all the free open access medical education from all of UH, not just the stuff we do, the medical director minutes, the pharmacy Fridays, all that's housed there. But most importantly, all the show notes for all the stuff, additional information, links for anything we may talk about. It's all part of the show notes. prehospitalparadigm.com, and then that rounds out all of that housekeeping stuff. So, guys, it's nice to be back with the usual group. Like I said, we've split up. We've had some really great recording sessions here lately. We've got a mental health episode coming out beginning of next year, and that was a heavy episode, and we got a lot of, it was a very important and necessary episode. But
it's a good episode.
Yeah, it was a very good episode, and we've got a pharmacy episode that we recorded here just in the last week.
Cool.
Yep. And next month we're going to be doing the new MCI look. So there's some new concepts in mass casualty, and we'll be talking about that next month. So let's get into the capnography here, and if I can, if I'll kind of start the discussion here, is in the state of Ohio, we're mandated to use it for any advanced airway placement as our go, no go, as our, as kind of the gold standard for placement. But the bulk of what we talked about in this recorded episode really had kind of revolved around, if you're only using it for that, it's just the tip of the iceberg, right? There's so many other things that you can do, that you can ascertain from that capnography number,
yep,
as well as that capnography waveform. So, anybody want to?
Yeah, I think it was just the other day, what was it, Monday, you stopped into the medic class, and in 20 minutes that you had with them, you opened up a whole broader spectrum of what's to be expected. I mean, obviously, I think Ed and I were just talking that you're about to introduce this into your lectures, and we're a little bit ahead of you because of our hours and the way it works, but we had just introduced it and started talking about it, and then it's like, okay, we're using it for airway, and then Scott shows up and he's like, what about metabolically, or what about, and it's like, whoa. It's like, okay, guys, hold on. We'll get there. We're going to walk, we'll get a crawl before we walk, but at the same time, they're like, this is cool. I can't wait to see it. So it's...
And I think that's the fundamental thing here is an understanding that, and we're going to talk just about that CO2 number for a second. That CO2 number is the sum of the patient's metabolism plus the patient's perfusion plus the patient's ventilatory status. So that one number is a broad brushstroke triage of, frankly, every important thing of the patient. Right?
Yeah.
It's just not the respiratory component of that.
It's not. It's modified by respiratory rate.
Absolutely.
But it reflects your metabolic processes inside your body, and your respiratory rate changes that number very quickly. So it's kind of all interconnected, and it goes with when you learn about metabolism inside the body with blood gas and pH balance, and essentially your lungs and your kidneys are the one kind of maintaining that pH balance. Yep. And that balance is done short-term by breathing, long-term by your kidneys.
Yeah, and it's just like, it's one of the things that we can use as a tool in a sepsis patient, in a respiratory patient. It's not just an intubated patient, it's not just an advanced airway. Plus, it really gives you a live feed as to the byproducts of their metabolism, right? To show us, is our patient perfusing well? Like if you get down to the sepsis road, why is the number lower? Because maybe we're switching from aerobic metabolism to anaerobic metabolism. Maybe our cells are not receiving as much oxygen, glucose. We're not producing as much ATP. That starts to whittle down. Their body is not getting rid of those toxins, byproducts. We're not perfusing it well enough, so our end tidal is going to start to fall because the cell is not receiving enough oxygen. So I think that's like my big to do with it. I think it really gives you a live feed of what you're doing, and it's affected by the respiratory rate. And one of the good mnemonics I remember from paramedic school was Rome. Respiratory is opposite, but metabolic is equal. So when we talk about some of the numbers versus the respiratory rate, and hopefully those are in some questions tonight that we want to talk even more about. But
sure.
It's not just,
it's just not, I've got a tube, yeah.
Correct, yeah. It's a multi-use tool that, if you're not using it more and more, then you're gonna
missing a valuable data point.
Yeah, 100%.
Well, and probably your first data point that you're going to have ROSC when you're doing CPR.
Yeah,
you're going to have an advanced airway in. You're going to see it spike up.
With the exception of pulse oximetry, everything else we do from an assessment standpoint is just sequential spot checks, right? So you sequentially you spot check a blood pressure. That doesn't change second by second, minute, second by second, right? There is a time after which elapses, depending on how you set your machine up, that you get your next variable, and the next variable, and the same thing.
Well, to your point, even a pulse oximetry. I mean, if I'm saturated at 100%, it might be a few minutes before I see a drop. Capnography, on the other hand, is very
my point being, constantly running in the background.
Correct.
Blood pressure spot checking, blood glucose spot checking, right?
Yep.
And if
probably a 12 lead
spot checking. But we really have few things. Now, to your point, pulse ox is running all the time, but it's behind.
If I sat here and held my breath now, it's going to be a few minutes for me to drop, as opposed to capnography. First of all, it's going to give you an instant apnea alarm.
Exactly.
And then you're going to see numbers change very quickly.
So you've got that constant and ongoing real-time triage, and you'll notice if you're using it as that assessment tool of metabolism plus perfusion plus ventilation, any of those variables change, your output, you see that on the CO2 first, right? So it's actionable information, and it's not terribly difficult to then ascertain with very basic assessment which of those things metabolism, perfusion, or ventilation is potential causation here.
Yeah.
And it's a live, I always say it's a live feed, right? To your point.
I love that, yep.
It's a live feed of all the things that you just mentioned, Scott. It's not delayed. You're going to see it. So if in your head I think, well, maybe I need to bag this patient more, right? You're going to see if what you're doing is improving the patient or not. It's a live feed. You're going to get, it's responsive to you and your treatment.
And your treatment.
To your treatment.
That's
Furthermore, I think that's the key with it is it's live, it's moving. So what your treatment is doing is going to, either move that number in the right direction, or it's a rule out and move the number in the wrong direction. So it's you're responding to it along with your assessment, treatment, et cetera.
And it's gonna, if you're doing it for every patient, as you should be. I made my class swear to it. It doesn't cost them a penny to use it. Every patient, throw them on. You might catch something that you weren't going to catch before. So if you use it on every patient, let's say that you see a shark wave. Don't just read the number, read the capnograph as well, and look for those. You're going to catch, acute respiratory problems, chronic respiratory problems. You're going to catch waveforms that make sense to you when you study it.
Kind of piggybacking on that, right? The value there is when you use it. It's much like a 12-lead EKG, right? Mm-hmm. I've had far more 12-lead EKGs. Like, I'm doing it more so out of routine, right? It's like, this is all subtle things.
Once in a great while, you're going to catch something that you weren't looking for.
More often than not, I was not expecting that, right?
No, and it helps. Let's say that you have a patient who's meeting SIRS criteria, right? Systemic inflammatory response, and you see, you get everything except maybe just 2 parts of that 3-part piece that you're looking for, and you see these numbers, and then you throw them on capnography, and it's almost like boom, I've got you. It's like looking. I like to think of it as looking for those reciprocal lead changes on a 12-lead. I have one more piece to look at now.
Yeah,
they're just as important at your facing leads.
Yeah, to your point, it's another tool. No different than like cardiac arrest versus sepsis. It's another tool. If I have a patient that has a fever that I know has pneumonia or has been coughing for a week and has had a fever, and I can differentiate between CHF and pneumonia now due to the acuteness or longevity of this problem, and then I put them on end-tidal, I could see that we are progressing. SIRS criteria is met. I get my infection. Now I could say, yes, this patient's septic because now their end-tidal is, maybe it's 30.
Absolutely.
So it's just another tool. No different than like if we start out with a patient in cardiac arrest, what would their end-tidal be? Obviously, if they're not breathing and they're not circulating any blood volume, then their end-tidal is going to be 0 until we circulate the blood, we oxygenate them. We want to see a number greater than 10 in cardiac arrest. And to Dr. Hill's point, as it starts to continue to rise up, maybe on that next pulse check, if my end-tidal is now jumped up to like 60 or 70, then I would probably expect to possibly have a pulse, and I might have ROSC now at that. So it's very responsive.
And I think
to your
the
point,
easiest way to explain that would be it's like putting gas in a vehicle. If I put gas in a vehicle and it's not running, right, I don't hit the ignition, for some reason it's not getting a spark, I don't have exhaust. So on a person, if I have ROSC, I start getting that spark, that exhaust, and the gas starts firing. That's what capnography is reading then. And why you would have an increase would be the fact that the engines are now running. And I think that that's just the simplest way to explain it. How valuable is capnography to you in the ED?
So it's invaluable in certain patients. Obviously, your cardiac arrest patients, it's very valuable for. Any respiratory distress patients, it is. I've got not better, more precise testing that I do for blood gas, but any patient that comes in, if they're an extremis, they're going to go on capnography.
But that goes back to, is that real time?
No, it's not real time. It's a spot check.
Still a spot check, right?
To that point, that we will space out our spot checks. So after you bring in an intubated patient in for us, or even like a post-cardiac arrest patient, we're going to get that blood gas on that patient. And
slip a lens.
Yep, sure did.
roll back in his eyeball.
Yep. We're going to get that initial blood gas on a patient, and then about an hour later, after we have them on a vent, we're going to recheck that blood gas because I want to see what direction they're going in. Are my vent settings correct? What do I need?
Or if the story matches and you have a capnography showing you something, and you go back in the blood gas, and lo and behold, you catch a PE early. It's nice to have those numbers.
The advantage you have from the ED perspective which is still information we should provide you, is let's just say you're getting that first gas, is now you can have some correlation, some mental correlation between what you find in your draw versus, right? Now, that's not a set thing, but we're talking about for this patient, right?
It's not, no.
A little bit of, you can at least draw some parallels in which direction you're trending, up or down.
Correct.
based on-
Your initial end-tidal CO2 is not going to match one for one for the blood
Correct.
test, but it's going to be the same ballpark.
Correct.
If you're high, I'm expecting high partial pressure of CO2 in the blood. If you're initial, once you put them on, ideally you're going to put them on BiPAP, or sorry, CPAP for you guys. See episode 1 of Prehospital Paradigm Podcast.
Let me shamelessly plug our first episode. Actually, don't go back and watch
No.
that. That's hard to watch.
Skip the first 10 minutes.
Yeah.
After that, it's pretty decent.
Content's good.
Yeah, content's so good.
What do I do with my hands?
Once your initial end tidal is going to be in the same ballpark as my partial pressure of CO2 in the blood, but that's going to come down once you start to fix them, right? So you're going to put them on CPAP, and you're should see that come down from 80 to 60s to 50s. It might even normalize on the patient. That means you guys are doing the right thing. That means with each breath, we're blowing off an appropriate amount of CO2, but it's still going to be retained in the blood because I got a lot of CO2 to blow off in that patient.
And I think to that point, the cases where your blood level of carbon dioxide and what we're experiencing on the exhaled carbon dioxide side of things, the situations are rare where it's going to be less than that number. So I think the working mind model that I go with is my partial pressure of CO2 is at least that.
Yes, that's safe.
It's safe, right? It's at least that. I know I'm at least here. There could be things going on in the background because of metabolism, perfusion, ventilation that are modifying my number, but it's at least that under most circumstances.
Yes.
So.
Now, the extreme case of that is if I don't intervene and I see the patient starting to slow down their respiratory rate, let's say they're at 25, 30, and they're starting to slow down to the 20s and the teens, and that number's dropping down, that's a sign they're crashing and need intubated. So a lot of details when it comes to end-tidal CO2, but I guess, do you have anything else you want to talk about? Or you want to?
But we'll get into that. Just piggybacking off that, not only will you see that numerical rate decrease in that situation,
You'll see the height of your actual capnograph
you'll
increase.
see the capnograph, the gram will change, as well as you'll start seeing, more than likely, as an increase in retention, and you'll see that number go up on every exhaled breath. So you'll have two things, one corroborating the other, right? It's that rate's coming down, that CO2 is going up, indicating respiratory failure, and then potentially,
I think actually reading the gram is almost as important. I mean, that's going to tell you so much. We alluded to it earlier. I mean, you can look at stacked breaths, you can look at retention, you can look at an asthmatic patient, you can look at, upper airway, pathology problems.
I like the analogy of the number tells you what's going on.
And the gram shows you what's going on.
The graph shows you where it's happening at, whether it's upper airway or lower airway.
It gives you more of a location.
It starts fine tuning that number to give you an actionable thing. So, you guys ready to get into some questions? So, not only were they voluntold that they had to be here, they were also voluntold that they had some questions ready for us. So again, Chris has got the mic there, and hopefully, so. We answered it already.
No one wants to go first.
All right, so my first question is, you had mentioned it earlier, if you were to get ROSC, that number would spike up. And in our textbooks, we learned that the number for normal is roughly 35 to 45. And you had mentioned a number, I think I heard 60. And I'm wondering why that number jumps so high after you get ROSC and why it doesn't just sit around 35 to 45.
So can I take this one?
Hit it.
All right. So if you have a patient, that's a great question. So if you have a patient in cardiac arrest that quit breathing, their heart's not beating, they're not circulating that blood volume, oxygenated blood volume, you go down to 0, right? So then we start CPR, we start to provide oxygenation, we start to circulate that blood volume. As you do that, you're starting to raise that number. So when you guys get to ACLS, you'll get to the point where it'll talk about you want to have CPR that's greater than 10. Well, with our Lucas device, we talk about we're going to see end titles that are going to be greater than 10 just because the Lucas device does such good circulation, and it'll oxygenate and perfuse the brain and the body so well, sometimes it'll actually move. So as you start to raise that number and then you get ROSC, all of those byproducts of metabolism that have sat are now starting to circulate. So it's going to take a while for that number to ever come back to normal for us, like in our setting. I don't want to say that it won't, but depending on your transport time, but you've taken it to 0 to now I'm circulating all of those byproducts of metabolism, all the toxins that have sat, and we're trying to get the body to metabolize all that to get back to your 35 to 45 to normal. And that could take a while. That could definitely enter you into the emergency department. Dr. Hill's going to see that patient, and then we might have to adjust treatment based on those numerical values and waveforms. But that's why. Unless I missed something.
No, that's great. If I could put just a little bit finer point on that, carbon dioxide is acid in the blood, right? So if your heart's not beating, acid's building up out in the periphery, and then when it restarts, you get this rush back in, right? If just to simplify all those concepts, so you're going to get this initial spike, but again, it's still predicated on the things that we started with, which was we know the metabolism was crap because the guy or gal was just in cardiac arrest, right? If the perfusion is still crummy, right, you may actually see a low number because even though all that acid is out there, all that carbon dioxide is out there, it's not going round and round and round because their blood pressure's
they're not
crap over crap.
40 by 9, right?
They're not perfusing
it's
well.
garbage. Right? And then as you see that increase, you'll see that subsequent increase in all of that free acid that was out kicking it, running back to the lungs, right? And the other thing with exhaled carbon dioxide measure, it's predicated on proper ventilation, right? So if you've got lungs full of lung butter from pneumonia or some other garbage, a big old pulmonary embolism, however you want to look at that, that may be affecting ventilation and again, affecting that number, which is why that kind of goes back to my conversation with Dr. Hill here is I know that if I see that number, my carbon dioxide is at least that number, but when he draws his sample, there's a pretty good chance that might actually be a little bit higher than that.
Nailed it. You guys have all learned about hypothermia, right? So
Ooh, this is good.
Body gets cold.
This is great.
Body shunts blood away from the periphery, right? Once you start to warm the body up, what happens? Core temperature is going to come up, and then what do we expect to have happen? Is core temperature going to continue to rise, or is it going to go back down? What happens? Anyone?
I haven't gotten there yet, man. It's like third day.
Apparently not. So what happens in hypothermia is your body has decided to essentially cut off blood flow to your extremities. So they're going to be super cold. It's only going to perfuse brain and organs. As the body warms back up, the body's going to start putting flow back to the extremities, and we actually see a dip in core body temperature because you're moving all that cold blood from the extremities back into central circulation. Same thing's happening with this what we're talking about here with CO2 and toxins. Everything's going to shunt away from the extremities. The body's going to try to keep. This is not really how it happens, but same way to think about it is it's going to only perfuse what it has to do to keep the body alive, and then it's going to start pulling in all the garbage collection, all the toxins that build up from the periphery back into central circulation. So there's a lot of toxins that kind of get shoved out there to stay away to keep the body alive. Someone else got a question out there?
I guess.
What are some causes for inaccurate readings?
Ooh, that's good.
Yeah,
Not breathing.
yes.
It's accurate. It's 0.
Making sure that there's a calibration period for end-tidal CO2. The first thing you should do after turning on your monitor is going to be plugging in whatever device you're going to use, not attached to the patient. So it's got to pull in a set volume, and it calibrates based upon what it takes in first, and then you should place it on your patient. That's one of the big mistakes that people make. I'll be honest, lots of times that doesn't happen in that correct order, but that's one of the big
What
things.
did you find, how much was this pulling?
I think it's like 50
ml.
50 ml.
So, yeah,
ml a minute, right?
The sample size,
Which is insane
the
if
sample
you think
size
about it.
of this device. Let's tune that a little bit. The sample size of this on a LifePak 15. I'm assuming it's similar
Which is a lot of
technology to
air it's
35.
pulling every minute.
Yeah.
But yeah, like you said, if I put
50
this on
mLs.
right now and then plug it into the machine, it's not going to have time to calibrate. So you really want to get this in first.
Because it has to know what essentially room air is. It's got a 0 on room air.
Yep. And I,
Some of the other hindrances too.
See the line?
Like-
Once the line comes across the screen, it's now calibrated and ready to go.
Some of the other things that can hinder your reading would be if you use the nasal cannula end tidal and their exhalation is not great underneath that little sampling area. You might get a false reading.
Mouth
you might get
breather.
Yeah, if they're a mouth breather, if they're breathing in and out of their mouth, like some of the elderly patients that we might see in a nursing home.
Pizza in the beard.
If they're breathing in and out of their mouth, you still might get like an apnea alarm or an inaccurate reading from the nasal prong probe versus just because of the way their exhalation's working. The other thing with a filter line, back to Scott's lung butter comment, is if
You beat me to it, yep.
If you intubate a patient that now you're ventilating and then whatever lung butter wants to come back up, it's going to go through this.
Aspirate, whatever is
Yeah, they're
coming
going to
up.
aspirate up into this point right here. And then it's going to kill your whole sensor, which does happen in a cardiac arrest to the
Absolutely.
point where you either need to suction your patient, throw that one away, recalibrate a new one, put it back onto the patient. Some of those things
The
can
answer
be
is
triggers.
all of the above.
All the above.
Yes.
No, the answer is all of the
So-
above, right? You're going to have to suction them, then scrap that
and this-
inline, and then
Replace it.
yeah, okay.
If you start getting inaccurate readings or you start seeing gunk in there, replace it. They're cheap. They're free if you're in our protocol, I think. Throw a new one on.
The other challenge
Dan's
can be too
freaking
if
out
you
right
put,
now. Nothing's free.
if you put a nasal prong end tidal CO2 on and then you place that patient on CPAP as well. So now I've taken a positive pressure device, put it over their face where I have the nasal prongs and it's trying to get that sample, but they're trying to exhale, but we're trying to give positive pressure ventilation, almost like a positive pressure fan at the front door of a fire, right? I'm trying to force everything in. Their exhalation coming out could give you not necessarily a 100% accurate number, but at least gives you a good number to know you're making good progress or not progress.
It's yeah. So that flow washout
Correct.
is really what you're experiencing there. But I also want to talk about that. Although that number is going to be even further off from the sample that he gets in the hospital.
Correct.
You still have something that you can work with and trend for the better, right?
100%.
So all of everything that we started with it being the sum of metabolism plus perfusion plus ventilation still holds true, even though we started a little bit lower. We can still trend and see how we're doing overall. Again, as
Your treatment progresses.
as it progresses, as an overall triage tool. And you talked about this nasal prong, and I think there's a couple little points that I'm not sure that everybody in the world wraps their head around. Is you think that these nasal prongs on here is what delivers the oxygen. It's not what actually delivers the oxygen. The CO2 sample is picked up from the nasal prongs on a non-intubated set like this, as well as what I affectionately call this beaver tooth here. So between the beaver tooth, if you're exhaling through your mouth or through your nose, should get picked up there. Oxygen, if you have these sets that do both oxygen and capnography sampling, oxygen is actually delivered under the nose. It's actually delivered in a bunch of tiny little holes that are across the bottom here. So one of the things we ask you to do in our cardiac arrest and our airway protocols is put a nasal cannula on the patient under your bag valve mask to help hyperoxygenate the patient before an airway attempt. Generally, it's an intubation, but it could be any type of advanced airway attempt. The reality is you probably have one of these on already, right, if they're respiratory failure pending arrest, but you actually want to change that out in this particular case to a regular old nasal cannula, 32-cent nasal cannula, so you're actually blowing oxygen in there.
Right into their nose.
Into their nose, yeah, rather than just making a nice little puff of oxygen underneath it.
Yeah, you're just going to get a higher percentage.
You get a higher percentage, and that's what we want. We want that higher initial reserve, because that way when you're in the airway for the shortest amount of time, which inevitably turns out to be a shit show, then you've got some reserves there, right?
And that you're working off the fact that oxygenation is passive.
Is passive. Oxygenation is passive, exactly. Yeah, we don't have to push it in, right? We just have to provide it.
Yeah, if I didn't have to breathe because oxygen was passive, if I could find out another way to get rid of carbon dioxide, I'd be fine.
Yeah, if we could like put a little machine on you that's just suck carbon dioxide
I wouldn't have
out,
to breathe
we could
anymore.
just put a couple liters of air in your head and you would live, right? You would passively
enough in there
oxygenate
already.
there's a lot, yeah. There's a lot of space in there. I don't know if there's oxygen, probably carbon dioxide or something, but so.
Moving right along.
That it. Got something over there?
So besides not letting the machine calibrate before you put it on the patient, or it getting gunked up and changing it out, what are some of the other biggest mistakes you see paramedics make with capnography?
Not using it.
I was just
Yeah,
going to
no,
say that.
that's 100%.
I was just going to say not
that's
using
100%.
it early. I mean, if you're pulling into the ER and you're just trying to check a box by throwing it on last minute, you're going to miss things.
And sadly, I have 4 or 5 stories that go like this. The capnography wasn't reading, it must be broke, and patient's actively trying to die. Okay, it was doing its whole thing. It was doing exactly what it needed to do, but we were discounting the result, right? We were looking for a reason for it not to be right, right? That's the other thing is, you put it on, if you get an error, if an error comes up, yeah, okay, I get it, it's not working. But because you don't have a waveform or you don't have a tracing, look for causes while you're doing BLS resuscitation of the patient for what's going on.
So what level of CO2
He's
would
got
we
a note.
see-
I don't like this.
What level of CO2 would we see in stroke patients besides like ischemic and hemorrhagic stroke patients?
Doc?
So, I'm sorry, besides or in both of those cases?
In both, sorry.
In both of those cases.
Either or. Would there be a difference, and what would they be?
This is
I think that more-
tough. So let's go
But
with
think
the.
more about a TBI, I think, than
Let's go with ischemic first. Let's go with an ischemic stroke first, right? Probably should be relatively normal.
I would expect a normal.
Normal-ish,
Or,
right? As blood pressure cranks up, I guess there's an opportunity there for it to slightly come up. So maybe normal, high normal, it would be where my brain would go. But I would not I wouldn't expect any wild abnormality here.
I would expect a normal end tidal as long as with an ischemic stroke. So we're not going to talk about Cushing's triad because that's going to start changing your respiratory status.
Yep.
I wouldn't expect a change at all. What I look for a change in vital signs from stroke patients is hypertension. I expect them to be profoundly hypertensive, typically systolics 180s, 200s,
penumbra.
220s. That's what I look for. I would expect a normal end tidal. Now, what happens with...
You already said it.
I know.
TBI.
Not TBI. So if we have bleeding inside the brain, and then we're increasing pressure and we're squeezing parts of the brain outside of the holes that are in there, and we're getting what? What's that called? I just said it too.
Yeah, there was a hint.
Increase intracranial pressure, which causes this triad of things for a patient to do, right?
It's Cushing's. Yeah.
Cushing's triad, right? So what's Cushing's triad?
Third day, man.
So
It's not their third day. Third week, maybe.
They're just a little nervous. So Cushing's triad in a stroke patient, right, is going to be, I'm going to have an elevated blood pressure, my heart rate's going to go down, and then I can have irregular respirations.
Yeah.
So that's where, if you're looking at that patient that you suspect has some type of intracranial hemorrhage, then you should be looking at those vital signs, being able to pick up on that. So if you're taking a blood pressure, you're looking at your heart rate, I should see an elevated blood pressure, I should see a lower heart rate, or heart rate that's going down and a blood pressure that's going up, and then irregular respirations. And with irregular respirations are going to bring a capnography that could go up and down. It just
I'm
depends
about
on
to say
the respiratory rate.
There's likely
so,
to be some variability in there. Yep.
Correct, because if you think about it, like going back to the end tidal part, if I breathe really, really fast, is my end tidal going to be high or low?
It's going to be lower.
Low, right? So that's why I said that respiratory is opposite thing. So if I'm breathing really fast, my end tidal is going to be low. If I'm breathing slow, my end tidal is going to be high. So that's one way to think about it. If you're all over the place, then your end tidal is going to be kind of going up and down, to your point with that patient.
Correct.
Depending upon it. Intracranial pressure too. He asked a very good question pre this when we went and visited the class. We talked about traumatic brain injury, end tidal, protecting the airway, sitting that patient up at a 30-degree angle.
Yep.
So I'm not, if I lay them flat and I lay that patient supine, what am I going to do to intracranial pressure? I'm going to jack it up, which I don't want to do because I kill more of the penumbra in that portion of the brain. The penumbra is the portion of the brain that's like in limbo that we
Salvageable.
could save, that we want to save.
I spent weeks in and out of neuroscience ICU with my mom when she had her hemorrhagic stroke, and I never noticed any big decreases or increases in tidal. She did have quite a bit of Cushing's going on at some points, and there was a lot of Cheyne-Stokes respirations, and during those episodes you'd see an increase in tidal, slightly. However, the patient next to her was a thrombolytic stroke, and I didn't see any changes at all ever. So to your point, I mean, I was there for weeks, and I got to it was kind of like a little trial that, I was just watching to see what would change and how it would change. And Cheyne-Stokes Cushing's triad is amazing to watch unfold in front of you, and then they go back and degas and all this. It's just insane.
And I guess we have to kind of preface all that with what I'm sure is the setup for a TBI question to come, right? Is this is in spontaneously breathing patients. Right. When we take control, then we're adding another level. We're adding control, right? So then we'll look for some different targets. So,
So my question has to do with sepsis.
That's you.
How
Our
does
sepsis guy's down there.
capnography reflect sepsis patients, and what pre-hospital interventions and treatments can we supply to these patients to improve their outcomes pre-hospital?
That's a great question.
Did AI write that question? That was awesome.
No, he was getting picked on a little bit.
He's a professional question writer. That was awesome.
I award you no points, and we are all sorry for having listened to you.
The best thing I Googled, okay? No, I'm just kidding. So that's a great question, Jake. So if you think about it, it goes back to kind of maybe a better way for me to explain it would be Scott's reference of we have this just acid hanging out there, right? So if we're not perfusing well and you have this acid hanging out there that's not circulating, our cells do not receive enough oxygen. Eventually, if your cells do not receive enough oxygen or glucose, which a cell doesn't store either one of those, it needs a constant supply of oxygen and glucose, you'll switch from aerobic metabolism to anaerobic. So we switch from with oxygen to without. We produce less energy, the cell starts to die, we get more of a buildup of toxins, and your end tidal starts to go down because I have a buildup of toxins. I'm only perfusing maybe my vital organs. A lot of times we'll also see an increased respiratory rate because your body's fighting that infection. Your blood pressure is starting to go down because you are going into a stage of shock, so you're not perfusing well.
You have the trifecta of all of those things.
So all of those things are starting to happen. So what does that tell us, right? So A, we have to recognize it. That's the big thing. You need to recognize this patient meets SIRS criteria, they're septic, I think this is their infection. You need to take early intervention on their blood pressure, whether that is with, because if you have an infection, you start to become dehydrated. White blood cells start to fight the infection, you become dehydrated, we give fluids. So we could start with a fluid bolus to try to raise their blood pressure, increase perfusion. If that's not sufficient, then we move into like an epi-push push dose pressor because we need more perfusion. I can tighten up my vascular access, increase how much circulating blood volume I have, increase my heart rate a little bit, and then now we can see, does this patient need to be ventilated? Because that patient is typically going to be breathing at a higher rate. Like I could think of the last septic patient I had was breathing like 36 times a minute, temp was like 102, blood pressure's in the shitter.
Yep.
Like those are the things we want to try to correct, and you can correct those. So you definitely want to give them fluids and oxygenate that patient, also check a glucose, and then see what I've done to try to increase their blood pressure. Has that helped, or do I also need to support them respiratory-wise?
These are some of the more
Too
satisfying.
bad of a rant.
No, not at all. I was going to say the septic patients are some of the more satisfying patients that we can take care of from the perspective of you can watch them get better in front of you.
Yes.
You're not fixing the problem, right? They're going to need long-term antibiotics, and there's going to be a hospital stay to fix. But you can get them in a really ugly situation with aggressive fluid management and pressors. We'll just be, again, we're not speaking not only just to UH's audience, but pressors. It doesn't matter what you're using, whether it's dopamine or epinephrine or push dose epi or whatever you use. Those things in the pre-hospital space in a very short time. You throw, a couple IVs, some pressure infusers. You can watch these patients get better in front of you, and you will watch as that blood pressure trends up, that heart rate trends down, that capnography is going to give you the feedback on, hey, all this stuff is coming together, hey, all this stuff is working. So, yeah, I mean, it's
Yeah.
But when you see those red flags, take it a step farther and, look for causation. If you have a patient who's septic, you're probably going to be able to find through either history taking or a hands-on physical.
Where's the source?
Where's the source? Don't forget that the skin is the largest organ on the body. Look for the source. And a wise man once said, who's a physician, seek and you will find, and that's totally true. You look for the causation of your sepsis patient, you're probably going to find them, and that's going to be one leg up on the doc when you get to the ER and say, hey, this is what I found. Don't reinvent the wheel,
Yeah,
and you have to have aggressive. I know this isn't a sepsis lecture. We're talking about end tidal, but you have to.
I said he was a sepsis guy.
You have
Poke the
to
bear.
aggressively treat that, like to your point, and asking questions about whether I'm going to give volume replacement with normal saline or I'm going to use a pressor. Because if you do not, then your patient is going to have a buildup of more lactic acid.
Yep.
Your body is definitely going to be in the anaerobic metabolism portion. You're not going to produce as much glucose. You're slipping into now moving over to septic shock, and they're going to go into cardiac arrest. So you have to
Irreversible
intervene.
shock,
Yeah, they're going to go to irreversible shock, and then they're going to die. So we have to intervene in these stages. And the end tidal is a great tool to use for that.
It is, and
Sorry,
somehow we're going to turn this
circle
into
back
we're going to make Sheldon proud, and we're going to turn this into a sepsis lecture anyway.
My good friends at Palmadine.
Sorry.
The one thing I just need to say about that is, although we start with aggressive fluid resuscitation, if all you've got is a 22 in the back of their pinky, right? And that's all the access you can get. Maybe it is, maybe it's not appropriate to put an IO in them. Regardless, let's say that stuff's running slow. You can even start, you don't have to wait for the pressors. You can, keep them out of shock.
Correct.
And let the fluids catch up, right? Because you can always turn them down. And I think we push so much on fluid resuscitation, like we think we've got to get 12 liters in. Don't put 12 liters. But you think you got to get all this volume in before you go to the pressors and leave them in a shock state, and that's bad medicine.
Yeah,
right?
you definitely don't want to leave them in a shock state longer.
If you can fluid resuscitate them in a short order, start there. But you can always trickle that.
They need fluid, but they also
they
need
need
antibiotics.
absolutely.
Yes.
Oh yeah.
And liters of fluid.
Liters.
But we do know that if we leave patients in shock states for too long, that leads to worsening outcomes, right? So there's a push now, even for us, to put them on pressors earlier, and that's typically after first antibiotics and liters in, we're reassessing, is their blood pressure getting better? Because if our blood pressure is responding to the fluids, I should have a systolic of 90, I should have a MAP of 65. If that's not the case, I need to really look at, okay, fluids aren't working, especially I should have 2 IVs. I'm going to be planning for, if not starting already, or my pressor and or getting my central access to start my pressor. So
Hi, I'm Dr. Hale. Here's your antibiotics and your pressor.
yes.
Excellent question. All right. He left
Hey guys,
you to manage that all by yourself?
I had to unmute it. It's horrible. All right, so this is kind of geared towards medicating when you're intubating a patient, or say they're like a long-term ventilation patient, and you're doing long distance. So the patient can go into bradycardia, and they talked about atropine in the book. And then you guys had mentioned in a couple of episodes about, your asthmatic patient going to bronchospasm. My question is, could epinephrine ever be a consideration to treat say bradycardia with bronchospasm for an intubated or, patient pretty much? Yeah.
Short answer?
Yeah.
Yes.
Yes.
Okay.
And as a matter of fact, some of the medications in that bronchospastic patient that requires airway management, we're actually going to choose agents. Let's say that we're going to take this patient's airway, we're going to intubate them. We're actually going to choose agents that do some of the same things as epinephrine. So increased bronchodilation, again, it's analogous to some of the effects of epinephrine, not directly, but we're going to stimulate some of those natural effects of
Alpha 1, Alpha 2, Beta 1,
natural
Beta 2.
epinephrine, right? And then we're going to use ketamine for that, right? So the short is yes, we can do that. Now, if they're so tight, let's say we put that tube in, they're so tight and you can't move any air. Yeah, absolutely. You can stab them with some IM epinephrine, or if their blood pressure is also soft, we've got the option to squirt a little bit of push dose epi in, and you're treating not only the blood pressure, but you're also then treating that bronchospasm as well. So yeah, absolutely, there's a place for it, and things that act like it. I just went to our medic program today and said, you have to spend time learning the sympathetic nervous system, basically for this. We've got, what was my count? There's 15 drugs in our drug box that have some direct or indirect effect on the autonomic nervous system as a whole. Many of those on the sympathetic nervous system. So yeah, absolutely.
Epinephrine's my drug of last resort in those patients. So someone's going into respiratory failure, they're in severe respiratory distress. It's my last ditch effort to give them an L-start epidrips on them, if that's what they need. Right? It's whatever the patient's needs, and they're going to either tell you or show you
that they like it.
Yeah.
Quickly too.
Yeah.
And don't forget too, I mean, if you're giving just albuterol or racemic epi and you're starting to hear wheezes, it's working. Give more. Like if you're giving it and you're like, oh, now I hear wheezes, I'm messing them up. No, you're fixing them. Give them more.
Yeah, because now you're moving air to wheeze, right? Yeah.
All right, so I had a question regarding pediatrics. So can Entitle be done on pediatric patients, and does it require any special equipment? And also with Entitle, do the values change as compared to an adult?
Yes and no. The answer is yes and no. Does it require?
That's a PD, isn't it?
That is.
It's an adult and pediatric, and then they do sell a different probe, where that's orange.
Yep.
They do sell a different probe for when you get down to the little ones for like an infant, because the tidal volume is different. So that piece of equipment needs so much tidal volume to get you the number and get you the respiration rate, and I believe it's yellow.
It's yellow. Yeah.
So we actually carry that in our P bag at our place, and it's based on the tidal volume about that. So that's one of the biggest pieces of equipment that you need for an infant, is just the differentiation in tidal volume versus that is deemed like adult and ped. So if you had a 6-year-old kid that you wanted to put N-tidal on, both of those things sitting on the table right now would give you an adequate, accurate reading.
Yeah, and I've put these adult ones on some
little ones,
fairly, 5-6-year-olds. You can make them work, right? But size-specific equipment beyond that, absolutely required. And then to the second part of your question, do we expect value changes? No, not really. We still have the sum of those three things, and the body is looking to make normal at all times by varying those three things, their CO2, thus their pH. I said earlier, what this really is about is, our CO2 is acid in the blood. What we're really talking about is balancing your pH, right? And so absolutely. So pediatric body does exactly the same thing. It might breathe a little faster, but it's also got a higher metabolic rate, right? So there's a reason they have a higher respiratory rate. It's actually not a mystery if you start stitching it all together, right? So. Great question. Yeah.
The only caveat to that is neonates. I would not.
Oh, thank you. I was going to make.
I would not put end tidal CO2 on a neonate because
we got learned.
Yeah, we did.
We got learned on our neonatal podcast. Yeah.
It's not helpful for neonates, and you're going to pull depending on how big they are. You could be pulling their whole tidal volume in just sampling end tidal.
That was the.
Yeah, good point.
Yeah, Dr. Oliker.
I feel like a preemie.
Yeah. Really interesting piece if you want to hop in and look at our talk on neonatology with Dr. Oliker, our neonatologist. She was talking about the waveform for an advanced airway placement is about it for the neonate. So you can use that as a go, no-go for advanced airway placement. But the number beyond that, because of the sampling size of the volume and their minuscule tidal volumes, actually causes some problem and may not be accurate. So yeah, I'm glad you remembered to say that.
All right, so my question is, how would you obtain a capnograph level on a patient who possibly can't handle anything near their face, whether they're hyperventilating or having like an anxiety attack from an injury, or say like CHF or something like that?
Ketamine.
No, well, I mean,
I thought you said it.
yeah, might be a heavy stick to swing, but sedative. I mean, treat that.
I mean, you got to treat your patient. We have advocacy towards our patients. So if calming them down is what they need as part of that, then yeah, absolutely. I mean, we have Versed, we have Ativan, we have ketamine.
Depending on how severe, right?
Yeah.
But yeah, that's exactly it, right? Is if their agitation is interfering with your treatment or your ability to treat, then take action, right? How many gallons of Versed do you give in a shift? Do you get it in? Do you bring drums in? Is there a tanker truck?
I don't give Versed, I give midazolam.
I always picture the teenager who just broke up and and now they have carpal tunnel syndrome and they're curled in and they what do they need? Carbon dioxide, really. If you put a simple mask back on them without oxygen, you might be able to blow back in, and then they'll calm down to the point where maybe we can measure capnography.
But again, treat that.
Treat that.
We have agents to do that.
And coach them too. I think is a big thing too. You have to form a rapport with your patient. A lot of people that are going to be having shortness of breath. I'll use this since you said CHF. I'll use that as the trigger word, right? And they have claustrophobia, and I'm going to shove this mask on your face. They're going to be afraid of it. And then if you just talk them into it for a minute, and you're going to say, hey, if you do this, you're going to be able to breathe better. Once they realize you're telling them the truth, they're going to like it, and then they're going to talk to you through the mask. So
we have a chronic CHF in town that I've intubated twice.
That's wild,
And when we go there the first time, before she had crashed,
perfect case.
We try to put CPAP on her, and she's fighting us. Well, she knows now. She calls early, and again, I've intubated her twice now. The last time we went, as soon as I showed her CPAP, she grabbed it and she knew exactly that this is what she needed. And it was a coaching moment. But yeah, I mean, that's the type of the patient that it's like, you really got to calm them down, coach them through it, hold it to their face, maybe have them hold it to their face before you strap it on. The new Palmidine CPAPs that we have aren't as bad because the mask is more comfortable, if you want all honesty, but they're not the old orange yellow boxes we had. They're comfortable. And they're not as loud. And
way to work the plug-in.
Just saying.
They're sporty. You put them in a sport.
You're getting so much better at it. All right.
Truth.
All right. So back in when we learned in basic school about hyperventilation, and going back to metabolic acidosis and metabolic alkalosis. We see a lot of acidosis in the field, but we rarely see the alkalosis in the field. In what situations and what conditions do we see this in the pre-hospital setting, and is there any treatments to help us intervene this prior to going to the hospital?
In a metabolic alkalosis?
Yeah.
You're not going to see a metabolic alkalosis. The only way, someone I'm sure online will correct me, but
If we caused it.
yeah, it's iatrogenic. You're going to cause the metabolic alkalosis by things that you do and give.
I.e. buckets of bicarb.
Yes. So you can.
Then that's it, right?
That's it.
It's a sodium bicarb. I mean, that's lots of it. And that's what.
That's what's going to cause it. So you're not really going to, you're going to see all of metabolism is acidemia. So the body causes acidemia. By definition, death is acidemia. Your body's going towards a lower pH.
I mean, unless you have maybe a dialysis center in town, there's a chance that.
Again, iatrogenic, right?
Yeah,
It's
yeah,
not
but it's causation.
the body's
It's
not going to do that.
right,
yeah.
right.
But that might be a time where we've shown up to our dialysis center before with somebody who was grossly, but again, they caused it.
They caused it, and they're probably giving you bicarb during infusions.
Yeah.
So during the dialysis session. So.
It's a really good question.
If you happen to know that and identify it pre-hospitally, I can't think of anything great. So you can't add acid, right? Nor can we stop them from breathing to let acid build up. Both are not good.
Well, normal saling's 7.0% pH. Maybe just give them a bunch of that.
Then you're causing the hyperchloremia.
Oh, my back.
Overseas, I think in Great Britain in the ICUs, they actually add hydrochloric acid in those cases, which is bizarre to me. I don't know that we do that in the States. I read that somewhere. Like, wow, that's kind of crazy. So no good treatment.
Just
on
some
our
Sunday
side of
morning
things.
light reading for you.
Yeah.
So
I'm a dork. I like to.
I know.
in short, you're not going to see a respiratory alkalosis. I'm sorry, a metabolic alkalosis. You can see a respiratory alkalosis. That's what the body's doing. So the body is causing the alkalosis to combat the metabolic acidosis. They just try to cancel each other out. It's all about hydrogen atoms.
What was the statement? I'm in a constant battle. I'm in a constant battle with hydrogen ions.
Yep.
So.
For respiratory intervention wise, what do we do for a DKA patient? Someone who's breathing off tons of CO and they have rapid and deep breathing. What can we do for them?
Let them breathe.
But yeah.
My God, man, let them breathe.
And flood them.
They are trying to fix. They are trying to fix the problem. If you try to intervene on these patients, badness happens.
The answer is don't intubate.
Yes.
And honestly, that's for any. Understand that the body can breathe faster than we can bag.
Or put them on a ventilator.
Well, yeah.
I mean, that's
The body has the ability to. So you've got 3 layers of muscles in your chest wall. They all work in congregation to cause your chest to expand to take a deep breath in and then squeeze to put breath out. When we're mechanically ventilating somebody, all we can do is push air in. We have no help of the musculature, so the body can breathe faster than we can bag. So if someone's breathing at 30 times a minute, let them breathe at 30 times a minute. I intubated one person once that was breathing at about 30 times a minute because the ICU wanted me to, and I regret that decision. It was a bad decision. I held off for hours, and the ICU wanted them intubated to go to the ICU, and I should have fought harder. I agreed to them, and the patient ended up getting worse because I took the airway
because you couldn't match. Yeah.
I couldn't meet their volume that they needed to breathe by themselves.
That's a hard thing to wrap your head around. If you know you've got somebody in a metabolic acidosis, they are trying to create a respiratory alkalosis by breathing super fast, right? And it's hard just to be like, the best thing I can do for you is to let this play out, right? Now, there are other things we can do, right? You're still going to provide oxygen. We're going to monitor carbon dioxide, of course, vital signs. I can get IVs in them. And you touched on the other thing is our
Fluids.
pre-hospital treatment is going to be a lot of IV fluid, right? Dilution. We were talking about
Dilution is the solution.
Dilution is a solution to pollution. It's not a fix, but it buys time. It's going to help dilute that acid, right? So we can help, but we really can't fix it. And fixing it is dangerous.
Yeah, I just think
and that's wild.
that Kuzmal
You look at
respiration
somebody
is just let them
breathing
go.
60 times a minute, and you're like, I feel obligated to do something. And it's hard just to be like, no, actually.
But we're there for ventilatory
you need
support
it.
once they pass out.
Yeah.
Once they're done running their marathon, you might have to be there to pick them back up.
But again, we still can't match.
No.
We can't match what they need. But great question. Yeah. Those are tough cases.
I've heard you guys speak about some different waveforms in previous episodes, and then we know about like the shark fin. I believe you guys said swimming to the left, and then you guys have talked about like the SpongeBob for like a normal waveform that you would see. What are some other semi-definitive or common waveforms that you might see on capnography?
In my mind, at 2 o'clock in the morning, it's a SpongeBob or a left or right swimming shark, right? I seriously personally break that down mentally to keep it simple for me so I don't try to overanalyze it, right? So if the slope is on the left side, that's exhalation. I can do a lot of things to help fix exhalation, and it's all wrapped around pharmacology, right? So those are going to be bronchodilators. I can do CPAP. I can do all kinds of things in that space. The other side's a little harder. If the slope is on the right side, that indicates some airway obstruction. That's tough because now we got to find what the cause of that airway obstruction is. But I'm looking for generally square. Are there a few other little nuanced things? Sure, like if you have somebody that you've given a lot of sedation to, right? And you're ventilating, I mean, you've got this SpongeBob, you got this SpongeBob, you got this SpongeBob, and then in the middle of that SpongeBob, you start seeing a little dip, right? That's called a curare cleft, and that means the patient's trying to wake up and take a breath out of your circle. But all that is an upside down little capno waveform in there. It's
It's
the exact same thing you're looking at. It's just in the middle of your complex, right? So again, I try not to diverge too far from that because those three simple things, for me, have done me very solid in just not overthinking it and just, do I have a problem over here, or is it relatively normal? The amplitude, of course, is equal to the number, right? So if I have a CO2 of 80, that means this thing's super tall like this. If I have a CO2 of 12, it's squished down like this. So I know what to expect as far as the height of the capnogram based on what my number is, right? Personally, I don't spend a lot of time, looking at that unless there's a trend in it, right? Like if all of a sudden let me do it backwards. How would you be looking at this? If you were looking at it this way, if it was tall and then, it was small, and then it's starting to get bigger, and it's not coming back to baseline, that means I'm rebreathing carbon dioxide, right? So that would be a situation where I've got this sampling cannula on, I've got a non-rebreather mask over top of it, right? I've got it set at 10 liters per minute, and then I see this stair step start working up left to right. I'm not flushing enough CO2 out of that mask, right? Your device also should be giving you a very specific alarm, which is unique to end-tidal CO2, right? Which is high FI CO2. And the FI CO2 is the fraction of inspired carbon dioxide. That should have zeroed out when we put the machine on, right? I started at a theoretic zero, right? So if you're starting getting high FI CO2 or you see that pattern that's kind of stair-stepping up, that's telling you that there's CO2 that's being re-inhaled with each breath. The fix to this is super simple.
Take the mask off.
Just turn up your flow, right? Turn up your flow to help wash that CO2 out. Like I said, if you start with somebody at 10 liters or 15 liters, maybe they need 20 or 25 to clear that mask out and get that FiCO2 alarm to cease and that waveform to come back to baseline. Is that good? Okay.
So you guys talked about recognizing ROS during an arrest by capnography. So is this conditional for each patient, or is there like a lot of errors that could happen that could prevent that from being a good way to recognize?
Good way to
ROS?
recognize
Yeah.
it. My response here, and I'd like to hear what John has to say, is generally, it's great. There's a few abstract situations, but it goes back to what I already talked about, right? Which is, it's the sum of metabolism plus perfusion plus ventilation. So like a big pulmonary embolism, right? You have a massive P, but you're also unlikely to get this patient. Well, you might get the patient back. A big PE where circulation is horribly impeded, right? But you're still likely to see some positive trend in the CO2. It might be minuscule in that particular case. I think generally, yes, I want to talk about some pharmacological interventions here in a second, but thoughts to his question?
You're probably not going to screw it up. So even on a cardiac arrest patient, again, there's lots of times, even for us, that we don't properly allow the machine to calibrate itself. CO2 is going to be so low at that point, it's not going to matter. So you're going to see the appropriate rise. So it's what's going to probably screw you up is the ER cutting your line as they move the patient over. But then you're going to lose all your capnography, right? You're not going to have a waveform anymore and be like, oh, it's on the patient, but I don't have waveform, and now I'm at number 0. So more likely there'll be equipment failure from you intubated, we've got blood in the airway, now that's blocking sampling.
Yep.
We're going to cut the line, it's going to be pitched between something. But those things are kind of easily fixed because you're getting a real-time number that we talked about with a real-time graph that's going to show you something changed. And it's probably going to be, what's going to mess up is the equipment.
And there is one pharmacological agent in our drug box that is going to give you a near immediate, assuming you've got good intact ventilatory system, an immediate rise in carbon dioxide, which by itself could lead you to believe you have ROSC when you really don't, and that's sodium bicarbonate. So sodium bicarbonate is going to take the acid in the blood, and it's going to turn it into two things. It's going to turn it. It's the old elementary school, volcano with an acid and sodium bicarbonate,
Yep.
right? It turns that acid into what? It turns it into water and carbon dioxide. So the acid, it's out there. The patient has no circulation, right? Acid's building up in the periphery. We already spoke to that. We then give a drug that takes all that and converts it into carbon dioxide. If there's enough circulation and if there's enough of a airway patency, then you'll see this immediate spike.
It's going to come up a few points, and then
it trends right
should
back
drop
down.
right back down.
That's the key point, right? Is the sustained one. You want to tell them your story about the patient you did give bicarb to, and you're
So,
like,
yeah, I thought
I expected to come right back down.
I wasn't expecting the patient to survive this, but I had students in the room with me. We were lucky enough that we had both nursing students and paramedic students, and we're like, hey, we're going to do this. We're going to watch bicarb come up. And I think we started like 15. I gave an amp of bicarb. It came up and it stayed up. It didn't come back down. So I gave more bicarb. It came up and it went up and it didn't come back down. And gave them one more, and then we got ROSC. So
To not every patient you give bicarb?
well, so my anecdotal, non-scientific evidence, and we've given 6 EPIs to a patient and given 1 amp of bicarb, and all of a sudden we've got ROSC. I've had these episodes where I give bicarb during my resuscitations. Asterisks, not in AHA straight guidelines unless you're treating like hyperkalemia. It's in there for that reason, but strictly not in guidelines. But as I said before, death by definition is acidemia. Medications in the body only works at a very narrow pH range. So what ends up happening is you give bicarb to these patients. They got 6 milligrams of epinephrine running through their system.
That's not working.
That's not working.
That's not working. Yep.
So now you change the pH enough that those receptors work and all that epinephrine hits, and then you'll get ROSC. So I'm a proponent, and I would love to do the research. It's hard to do this research, but There's papers out there that suggest that giving early bicarb is beneficial. Bicarb is something that's kind of swung back and forth on give, don't give. We're now in the don't give for the last 8 years.
Don't give routinely.
Don't give routinely, correct.
Let's also preface with, especially if it's an EMS code that we've brought you, they've been dead for a minute.
Yeah.
Right.
Well, and that's the other thing that not end title related, but a lot of times you guys will bring us patients and we ask, when did the call go out? And you guys have been working your butts off for 30 minutes doing CPR, loading the patient up, driving them to the emergency department, and you come to us and you look down your watch, oh yeah, they called us an hour ago. That patient has a 0% chance of a good neurological outcome, and we're going to call it because they've been down for just so long. So I know that a lot of people that are new to either EMTs or medics, they get discouraged, like, oh, we did all this work just to show up at the emergency department and they didn't do anything. Well, it's because you guys did everything you're supposed to do. They got all the care that was appropriate for the past 40 minutes that they were in your care during your initial treatment, and then continue the treatment even during transport. There's just nothing left for us to do. You guys did it all. They've been down for, my cutoff is generally about 45 minutes, but 45 minutes to an hour, I'm gonna do a round of epi, maybe 2 rounds of epi, and I'm gonna call it if I don't see a change.
And that is why our protocols are structured the way they are, encouraging you to work these patients on scene, right? Work them on scene, until you get to one of two stopping points. Well, I don't say a stopping point, one of two decision points. I get ROSC, and then I load them, and then I go to the hospital, or we meet that 20-ish minute time frame. We're approaching 0% of potential for good neurological recovery, and we'll field terminate, right? And that's why they're structured that way, to his point. He doesn't have many magic bullets for.
No, I don't.
But I mean, Ed and Chris, I'm sure, are telling you, because they're good instructors, that a good ALS paramedic squad crew on scene at somebody's house is exactly what the patient needs. And other than maybe 1 or 2 minute things, they're getting the same care that you're going to get to ED with people particularly caring for one patient, not 30.
Correct.
Yeah, they're going to get the highest chance of survival is right there in the living room where that cardiac arrest occurred with you.
And so if you want a good example of that, I feel like we're plugging our podcast a lot. One of our early episodes, Saving Our Own, my patient was a firefighter when in cardiac arrest in front of me. We worked him on scene, intubated him, multiple rounds of drugs plus shocks, and we didn't move until we had everything set, and then we started to roll to the hospital, and we got ROSC literally as we kind of left the fire department, but we did everything to set up for a safe transport of that patient. His scenario was a little bit different because of the type of arrest he was in that we needed to transport him in. So we needed to go, but we didn't go 10, 15, 20 minutes, again, until loaded, IV established, intubated, multiple drugs, multiple shocks.
Initial critical events.
And yeah, all the initial critical stuff, and then we transported. Another good episode was post-cardiac arrest care from earlier this year with Dr. Jordan Singer.
Yep.
By definition, you have a patient that just now came back to life. They're critically ill, and the worst thing you could do is just get up, move, and go. No, slow down. Make sure the patient's safe for transport, because you don't want to be moving the patient down a hallway and all of a sudden lose pulses again. And the best thing that patient needs is either defibrillated and definitely needs CPR started. So make sure that's what our protocol is built around. It's built around providing the right care at the right time, and that can be done by any ALS provider in the field. They don't need to come to the hospital.
Besides confirming a tube placement and looking for ROSC, what are some other things we could be looking at capnography when bagging a patient?
Rate. Keep an eye on your rate. I mean,
Yeah, so I think that's the variable that a lot of people forget about, right? Is you might be mentally counting in your head once every 6 seconds or whatever you're doing. And I'll challenge you to do this next time you're bagging somebody, right? Is even with, let's just say you're mask bagging the patient, right? So you just have a mask. You can put this same adapter between the mask and the BVM. Is bag the patient at what you think mentally you should, and then look over at that rate, right?
And it's at 30.
And it's at 30, right? It's like, because it's like 1.56, 1.56, 1.56, 1.56. It's you're generally way too fast. But other than trying to get that CO2 into any particular range, I think that rate's overlooked.
Yeah, the rate's overlooked. There are companies out there making advanced bag valve masks now that control your rate, but even with that, I have found that I can bag at about 5 breaths a minute.
The other thing too, on a serious note, to answer your question, is a lot of people look at end titles like it's only an ALS skill, it's only a paramedic skill, and back to Scott's point here about bagging, right? So if you intubate somebody and let's say you're the only paramedic on that ambulance and you have 2 EMTs with you, as soon as you intubate them, what do? I'm going to pass off and be like, if Caleb's my EMT, I'm be like, all right, I need you to bag them. And I think that's often overlooked too. So for people that are listening that are EMTs where they think, oh, this is just this boring job, I just have to sit here and squeeze this bag, your job's actually extremely important.
Most important.
It's very important, because if you're breathing too slow and you're not ventilating them enough, I could lower their heart rate, so I might need to increase my ventilation. So back to the rate issue, that's a very important skill. It doesn't matter if you're an EMT, advanced, or a paramedic. Rate control of that is huge.
The other thing, kind of building off that rate, we talked about it. We may as well we'll just continue to plug things in our airway series about ventilators and tracheostomies. One of the things we talked about is if you have a situation where a patient's ventilator has failed, well, they were at a set rate in most cases. How can you best match what they were getting on their ventilator is match that number, match that ventilatory rate on your capnography. So I think it's just dead in front of us all the time, but I think we often just kind of overlook it because we're looking at the number or we're looking at the waveform, the sexy stuff. But the rate's the big,
especially a long-term vented patient, right?
Specifically,
they're accustomed to. I only get 400 milliliters or 450 milliliters of tidal volume. I get 14 breaths a minute every single time. Like, their lungs become accustomed to that. So if you start squeezing that bag like an accordion or increase the rate substantially, you can injure their lungs. So that's something we have to pay attention to.
Crazy case.
I have a question kind of circling back to the diabetic ketoacidosis question. If you have a patient who's in acidosis, I'm not sure if this stems from my ignorance to our protocol, but do we have anything in place to be able to give bicarb to these patients so that DKA patient isn't breathing so heavy? Because you say they're trying to breathe off those wastes, and due to their acidosis, would bicarb bring that down, and is that a placement in our protocol?
My colleague here is chomping at the bit to answer that question.
I'm not chomping at the bit. I've talked a lot about bicarbonate in the last few weeks.
Yes.
No, it's not.
It's a spot-on question, right? Yeah, it's a question that absolutely needs to be asked and absolutely needs to be answered. He's answered this question probably 12 times in the past 2 weeks.
And it's a question that makes sense, right? I've got an acid problem. I want to throw a base at it.
Yeah.
So, no, it's not indicated, really. There are, if you go out there and look, depending upon how bad the acidosis is, how bad the DKA is, we do sometimes give bicarbonate. That's not a wrong answer. It's not the right answer either. You can do either or. There's even different rates that we give insulin drips at. There's whether you bolus them or don't bolus them to start. And there's different opinions on how to do that. This is a personal opinion. I don't give bicarbonate to those patients unless someone smarter tells me to do it. And the real simple reason for that is 90% of what we do is to support the body. The body knows what to do in that circumstance, that it's doing everything fine. I want to inject as little as I possibly can not to kind of muck up what's going on. So if we're talking about respiratory stuff and they need oxygen, we're going to give them supplemental oxygen. If they need a little bit of extra pressure for that, we're going to put on CPAP. Those are the things that we can do. Adding bicarbonate, it's going to change, it'll instantaneously change their pH in their body, that their kidneys and their lungs and everything else is working very hard to set at a certain rate. I don't want to mess with that. I want the body to do what the body's going to do. What we actually look at for this and what we should be looking at is long-term, what are the kidneys doing in response to this? Are they able to keep up? Are they able to keep up with that bicarbonate? And do I need to assist the kidneys in this? It's not an instantaneous thing. I show up, they're in DKA, you get bicarb. It's we're going to see how this plays out over a few hours, 6, 12, 18, 24, and then possibly add on the bicarbonate, and that's to help the kidneys. That's all it's there for.
And when that's added 6, 8, 10 hours down the road, it's not a giant slug.
No.
It's calculated and titrated over time.
Thank you.
Yep. It's a good question.
It's a very good question, yeah. That's it? Nothing else? Hey, actually, those are some great questions.
Yeah,
you guys did, very good. We appreciate all of that, and all of you that were out there watching. Are we at the hour?
We're at the hour.
We're at the hour, and we're at the hour plus. So, again, prehospitalparadigm.com, all the show notes, all of the previous episodes, all of our other open access medical education, all packed in there. I guess we have one last thing we need to do, and that's determine where, while you're pushing buttons over there, let's figure out where we're going next.
So the one thing I do, two things I kind of want to plug for people listening on the podcast, recorded or YouTube. The best thing you guys, all 26 of you, could do is go to our YouTube channel, Prehospital Paradigm, and follow us there.
Hit the subscribe.
Hit the subscribe button.
Yep.
And then the second thing is for when you're done with paramedic school, and for anyone that has a current certificate in the state of Ohio, we offer free CE for all our podcasts that we do. There's not a time requirement on the software we use that you don't have to go in and re-watch the episode. If you've already listened to the episode either via podcast form on your favorite podcast app, you've watched it on YouTube, just go in there, take the quiz, get the credit. Super easy. We've had hundreds of people do it already, but it's just another free service of what we offer here. So next month.
All right, let's see where we're going next month. We had 5 options in there. So which of the 5 are we going to?
Chardon.
We're going to Chardon. So Chardon, we will see you next month for our Mass Casualty Live. Thanks, everybody. Have a great night.